Welcome all to the today's class. We begin with our quote, Master MRCOG with concept-oriented clarity. So today's topic is going to be very important from MRCOG examination point of view. It is important from part 2 as well as part 3 point of view. For part 2, generally lots of SBAs, EMQs, at least 2 to 3 EMQs can be asked from this particular topic. And for part 3, there can be an OSCE station. So today's guideline is NICE Guideline, Management of Diabetes in Pregnancy from Preconception to the Postnatal Period. This is published in 2015 and last update is 2020 update. Okay. So what exactly the guideline talks about? It begins with the preconceptional care. Okay. So one of the important thing which we should remember when we read about the guideline. So even if we say it is a blood glucose level, but primarily we are referring it to the plasma level because all the evidence, whatever is there, it is on the plasma glucose. Okay. So glucose meters is calibrated to plasma equivalents. Okay. So from examination point of view, even if values are quoted, we will consider it is a plasma equivalent which is given. Okay. Plasma equivalent, even if it is termed as a blood glucose. Then coming to the preconceptional counseling, what are the things which we need to discuss? The aim of the preconceptional counseling is to give the positive pregnancy experience and reduce the adverse outcomes. Okay, so the pregnancy should be a positive experience with the minimization of the complications or the adverse outcome. So what is the importance of good glycemic control? Okay, if there is a good glycemic control, there will be reduction in the incidence of the miscarriage, congenital malformations will be reduced, and stillbirth and neonatal death will be reduced. Okay, but remember, with good glycemic control, we can reduce the risk, but we cannot eliminate the risk. Okay, so this you have to remember that we can reduce the risk, but we cannot eliminate the risk. Now let's talk about the glycemic control, and this glycemic control, that is the preconceptional, periconceptional, throughout the antenatal period glycemic control is the central determinant of the outcome of the pregnancy. There are high chances of hypoglycemia during the pregnancy, and it may be associated with impaired awareness. In the sense, normally when there is a hypoglycemia, the patient will have symptoms of tremors, there can be sweating, etc. But these symptoms may not be there in pregnancy. Okay, then nausea, vomiting will affect the glucose control. Then the fetal growth is very important because it will be affected by the glycemic control. There are increased incidence of the large for gestational age babies that will lead to the birth trauma, requirement of the induction of labor, cesarean section. So operative delivery incidence is increased. For neonates, there are high chances of hypoglycemia and NICU admission will be there. And in long term, the child will have the risk of obesity and diabetes, while the maternal complications such as retinopathy and nephropathy will be there in long term. Okay, so these are the complications of the diabetes for the mother as well as baby. Now, what are the important practical counseling points? So whenever a patient comes for a preconceptional counseling, we need to discuss about the diet, exercise, and weight. Okay, so they carry a very important role in the management. Then in labor, we need to mention that the tight glucose control is important. And not only that, early neonatal feeding is required. That will reduce the incidence of the neonatal hypoglycemia. Okay, baby may need an ICU admission, and the risk of early neonatal morbidity, that is within first 28 days, is little high. That also we need to tell in the preconception counseling. Now, what are the other things which are there in the preconceptional period? By the time this glucose control is achieved, what are the things which we need to do? First thing about these diabetic patients, the pregnancy must be planned pregnancy. So it has to be a planned pregnancy. Start education from the adolescents, especially those patients who are having type 1 type of diabetes. Education should be started from the adolescents itself. Then they should be on effective contraception till they decide to conceive. Okay. So the choice of contraception will be the patient preference and will depend upon the risk factors which are associated. Okay, if there is only diabetes without any complications, OCPs are allowed in the diabetes. Okay, now coming to the advice before contraception, use contraception until good glycemic control is achieved. Okay, so till the good glycemic control is achieved, she should be using the contraception. Longer the duration of the diabetes, there is an increased pregnancy risk. Okay, so these patients, what is expected? those patients who are diabetic on medication, they will require the change in the medication. The more frequent monitoring is required, and their follow-up will be more. That is the increased healthcare contact will be there. Okay, if they are having long-standing diabetes, their risk is also increased, and they will need to have the frequent follow-up with some medicine changes and more frequent monitoring. And we need to give them the information about the local care pathways and emergency contact number. Okay, so diet, weight control should be advised them. Diet is to be individualized dietary advice should be given. You can take the help of the dietitian. Then about the weight, if the BMI is more than 27 kg per meter square, advise weight reduction. Okay, so in the preconception counseling, we need to assess the patient if her BMI is more than 27 kg per meter square. So this can be asked as either SBA or EMQ, such and such patient who is diabetic, she is planning the pregnancy, and these are her parameters. And if you find her BMI as a more than 27, the next important step will be advise weight reduction. Okay, then further thing, there may be another option of folic acid also. Okay, low dose will be given, high dose will be given, but the first thing will be the appropriate and the most significant will be advised weight reduction. Okay, then folic acid 5 milligram per day, preconception to 12 weeks, it should be there. That reduces the neural tube defect incidence. Okay, then coming to the glucose and ketone monitoring. Now, what kind of monitoring for the glucose? It is the self-monitoring, SMBG. Okay, self-monitoring of blood glucose is to be done, and it may be intensified monitoring with the fasting pre-meal and post-meal, especially if any therapy change is there. Okay, so if any dose change is there from medication, in the insulin is added, or any therapy is converted from diet plus exercise, she is added with medicine, then it will be intensified, and we will have strict fasting pre-meal and post-meal monitoring. Okay, so it is the self-monitoring is indicated. This monitoring is to be intensified with any therapy change. Then what about HbA1c monitoring? It will be monthly HbA1c monitoring. Okay, so very good self-monitoring is advised during this preconceptional period. HbA1c monitoring will be monthly. This self blood glucose monitoring will be intensified with any change in the therapy. Okay, especially if she is type 1 diabetes, then ketone monitoring is also indicated. Ketone testing is advised if there is a hyperglycemia or if there is any illness. Okay, now what are the targets before the pregnancy? This is also very important from SBA point of view, these targets. Okay, so especially with the capillary blood glucose targets, the fasting, that is on waking, the blood sugar should be between the 5 to 7 millimoles per liter for type 1 diabetes, and for pre-meal it should be 4 to 7 millimoles per liter. Okay, so the patient who is non-diabetic in preconceptual period, we are going to discuss about the lifestyle changes, we are going to discuss about her BMI, we are going to provide her contraception till the glycemic control is achieved, and what should be the target that we are discussing now. The fasting should be between 5 to 7 millimoles per liter, and pre-meal should be between 4 to 7 millimoles per liter. Okay, then HbA1c target. HbA1c target will be less than 48 millimoles per mole, that is 6.5%, and avoid pregnancy if it is more than 86 millimoles per mole, that is 10%. Okay, so these all values are important from the SBA point of view. Okay, so preconceptual targets for the blood glucose in diabetic patients. So fasting will be between 5 to 7, pre-meal will be between 4 and to 7. HbA1c target will be less than 48 millimoles per mole, and pregnancy is to be avoided if the HbA1c value is 86 millimole per mole or 10%. You please remember both these values. Don't remember only 6.5% and 10%. Remember these values also. Okay. So sometimes they will be given only these millimoles values in millimoles. Okay. So 10% is corresponding to 86 millimoles, and 6.5% is corresponding to 48 millimoles. Okay, so any reduction in the HbA1c will also reduce the risk of congenital malformation. Okay, so that needs to be explained in the preconceptional counseling. Now, what about the drug management in this preconceptual period? If she is on metformin, it can be continued. Okay, though it is off label, but it can be continued. Other oral agents are to be stopped before the pregnancy, and if required, she can be converted or she can be started on insulin. Okay, so metformin can be continued. Other oral agents are to be stopped before the pregnancy, and instead of other oral agents, the use of insulin can be made. Okay, then what are the different types of insulin which can be advised? Okay, so in the rapid acting insulin, aspart and lispro is safe. Okay, a long acting isophene insulin, that is NPH, that is the first choice. Okay, and insulin analogs such as detemir and glargine, that can be continued if she is already taking and if there is a good control. Okay, so these are actually long acting detemir and glargine. These are insulin analogs. Primarily you will not start this, but if she's already on these and she is having good control on this, then only you will continue. So generally, if there is a good glycemic control, we will not change this analog, but we are not going to primarily start on this detemir or glargine if she is not on this. Okay, so the preferred agent will be long acting, will be isophene insulin. That is going to be the first choice. Okay, rapid acting generally to cover the post meal hyperglycemia. It is rapidly acting, and short acting aspart and lispro, that is also safe. But detemir and glargine, that will be only continued if she is already having the glycemic control over this. Okay, then another important thing, long acting analogs, they are off label but allowed if she is stable on it. Okay, then other drugs. Okay, for complication, AC inhibitors we have to stop, ARB inhibitors, ARBs we have to stop, and statins also we have to stop. Now, access to preconception care at every contact, discuss the pregnancy planning, record reproductive plans, and provide supportive environment and encourage partner involvement. This education is very, very important. We need to offer structured education program quite early, and it must be done before stopping the contraception. Okay. Now, another two important things which are coming from examination point of view. One is the retinal assessment. Second is the renal assessment. Okay. Now, coming to the retinal assessment, we are still in the preconceptional counseling. So it should be done before pregnancy or within 6 months. Avoid rapid glucose correction before retinal assessment. Okay. So if there is a hyperglycemia, the patient wants to conceive, definitely we are going to go for correction of the hyperglycemia. We will advise contraception, but when there is a hyperglycemia, do not rapidly correct it unless you do the retinal assessment, because retinopathy, if it is there, it will get worsen with the rapid control. Okay, so retinal assessment is essential before tightening the glucose control, as rapid correction can worsen the diabetic retinopathy. This is the thing which you should remember. The next is a renal assessment. So always check the serum creatinine, albuminuria, and eGFR. Okay, so there are indications for the referral to the nephrologist. These indications also you should remember. Creatinine more than or equal to 120 micromole per liter. Albumin to creatinine ratio more than 30 per millimole. eGFR less than 45 ml per minute per meter square. Okay. So this is the these are the indications. Creatinine value, albumin creatinine ratio, and eGFR level. Okay, eGFR level less than 45 ml per minute, albumin creatinine ratio more than 30 milligram per millimole, and creatinine level more than or equal to 120 micromole per liter. Okay, and remember, this eGFR is useful only in the preconceptional period. During pregnancy, eGFR is not useful.